Assalamu alaikum. We're gonna start in about 5 minutes, inshallah.
90 عام والشهادة علمنا، وحده وتوحيد وسيف تثنى. من يوم أبو ترك تنهض ونجل، قاموا لشام العز محد تونى. خلف رياجيل على قدر الأحداث، وانصاح صايح قالوا وفداك حنا. وجسنا على المنوى وعيت على الغير، وما كل عشاق وصل ما تمنى. وإن قالها الله نجعل الحلم واقع، ونطوع الصعبات بالعزم منا. نبني عمار الدار بأفكار وعلوم، ونصنع سلاح جيوشنا في وطننا. طق طبول النصر في يوم مجده، وسلوا سيوف بالشجاعة تغنى. من يوم تركتنا يا الزمان تولى.
Assalamu alaikum. Welcome back from your lunch break. I hope you had a nice pause. We're going to be starting on an important talk with our next speaker, inshallah, which will be Dr. Saleh Al-Nas, who will be presenting a topic titled Maximizing Outcomes, Optimizing Treatment and Comprehensive Care for Patients with Diabetes. I'd like to extend my welcome to Dr. Saleh to the stage.
السلام عليكم. جزاكم الله بالخير جميعا. Thank you for nice introduction. It's my pleasure to be with you today, talking about optimizing treatment and comprehensive care for people with type 2 diabetes. The outlines for our talk will be about the pathophysiology of type 2 diabetes, and we will review quickly the non-pharmacological and pharmacological interventions for people with type 2 diabetes, trying to explore what's called holistic personal centered approach, focusing in both glycemic control and preventing DM complication. It's good to remind ourselves about the pathophysiology of type 2 diabetes, trying to adopt what's called a pathophysiological approach when you are dealing with people with type 2 diabetes and trying to manage their hyperglycemia and to prevent their DM complication. This is one of the famous hypotheses. Prof. Taylor called it twin cycle hypothesis or bicycle hypothesis. If you imagine, this is like bicycle, and the first wheel represents the liver, and the second wheel represents the pancreas. So simply, type 2 diabetes represents ectopic fat accumulation into two main organs, the liver and the pancreas. So if you get excess calorie intake for chronic time, whether it's carb, protein, or fat, all the extra calorie will be stored as a fat. First, it will be stored in the subcutaneous storage, and it has its own capacity. Then it will be deposited into organs. One of the biggest organ is the liver. So you will get fat deposited in the liver, and this will lead to insulin resistance to the basal insulin, and it will drive increase of the hepatic glucose production. And this will lead to increased plasma glucose, and also this fat, it will be expelled as VLDL, and it will deposit into pancreatic beta cell. And for those who have beta cell susceptible to develop type 2 diabetes, they will get ultimately what's called first phase insulin secretion to be disturbed, and this will increase postprandial glucose excursion. So we cut it simply. We have the liver, and this is responsible for increased fasting glucose because of the increased hepatic glucose production. And we have the pancreas. If we get fat deposited in the pancreas, it will impair the first insulin secretion, and this will increase the postprandial glucose level. How to test this hypothesis? Simply, if you decrease the fat in the liver and decrease the fat in the pancreas, supposed to be theoretically that you are normalizing the fasting plasma glucose and normalizing the postprandial glucose. How would you decrease the fat into the liver and pancreas? Weight loss, excellent, thank you. So we are on the fundamental treatment for people with type 2 diabetes, which is lifestyle, and the bulk of that lifestyle is reducing the weight. So he tested his hypothesis with this trial. It's called Counterpoint study, and he induced weight reduction by average 15 kilogram by adopting hypocaloric diet, almost 600 kilocalorie per day. This is experimental. Over 8 weeks, it's meal replacement liquid formula, aiming to decrease the weight and decreasing the liver fat and pancreas fat. Look to the result. He's monitoring the liver fat by what's called MRI scan, and from day one, there's decrease for the liver fat alongside with the decrease of the fasting plasma glucose. All the hypoglycemic agents stopped from day one. And you see the rapid normalization of fasting plasma glucose from the first week up to the end of his experimental study, the 8 weeks. So you got normalization of fasting plasma glucose evident by decreasing the liver fat. And this is the first wheel. What about the second wheel? We have the pancreas, and this is went gradually. There was decrease in the pancreatic fat, but it was gradual, unlike the liver, it was rapid. But at the end of the 8 weeks, there was decrease of the pancreatic fat, followed by improvement in the postprandial glucose level with the restoration of first phase insulin secretion. Can this translated into primary care? He tested with what's called direct study. This is one of the landmark trials. We have it. Testing the lifestyle intervention for people with type 2 diabetes conducted in 49 primary care centers, randomized into almost 150 people, underwent experimental and interventional hypocaloric diet aiming to lose 15 kg, and the other arm best managed with guidelines. And this is continued for 12 months, then extended to 24 months. There was approximately 15 kg weight reduction and was sustained over the first year. And it induced 46% remission in type 2 diabetes in the first 12 months. And the remission declined from 46 to 36 over 2 years because of weight regain. So we can conclude from these two trials that the principal management for people with type 2 diabetes is weight reduction. Okay. This is done with the dieting and with a low-calorie diet to induce weight loss. What about the physical activity? It's not only moderate physical activity aiming to have 150 minutes per week, but also we have evidence suggesting to break the prolonged sitting. It has evidence for that, and even increasing the stepping by 500 steps, this associated with reduction in the cardiovascular mortality and morbidity. The new about the ADA, they put alongside the physical activity, what's this? The sleep, and they emphasize onto the sleep component, both quantity and quality. This is part of the lifestyle reinforcement for people with type 2 diabetes, the quantity of sleep and the quality of sleep. One of the new updated and stated by the ADA guidelines, the new release of the US Endocrine Society, they reinforce about vitamin D, empiric vitamin D supplementation for people with high risk to develop type 2 diabetes. And they have evidence behind that it prevents progression to type 2 diabetes in very high risk pre-diabetic people. And this is the new release of the ADA 25 vitamin D therapy, and has recently advocated by US Endocrine Society. So I know the evidence behind it might be weak, but especially in our community, we have increased level of hypovitaminosis. This is to be encouraged as empirical therapy for people at high risk of diabetes. So we're done with the non-pharmacological intervention, the diet, the physical activity, and we reinforce the sleep. And we talk about the recent release of the ADA 25 update about empiric vitamin D supplementation. Before starting the pharmacotherapy, you would ask yourself about the A1C target. Would I go very strict or less strict to balance benefit versus risk? And this is to be determined based on your patient individualized characters. Would you go less strict or more strict? Depends on the duration of diabetes, the hypoglycemic risk for that specific patient, presence of cardiovascular or comorbidity, and if he's bedridden or he already have established complication, you might relax the A1C target. The ADA adopt what's called personalized central care for people with type 2 diabetes. It means that you put the patient the center of your care, trying to optimize the hyperglycemia and prevent complication. You assess your patient characters, his current lifestyles, presence of comorbidities, any specific factors, any compelling indicator for specific medications. Then you will set shared decision making, set the SMART goals with your patient and to be implemented. And don't forget to monitor that and to reinforce your goals and treatment to avoid therapeutic inertia. So simply, you will choose medication that manage the hyperglycemia. Keep in your mind to manage the weight with this medication and to reduce the weight, because most of people type 2, they have obesity. And don't forget, diabetes is cardiometabolic disease, so don't forget the other cardiovascular risk factors, blood pressure lowering, lipid management, he needs antiplatelet, and counsel and promote smoking cessation. And to choose agents which have evidence of cardiorenal protections based on the comorbidities your patient is having. Is he having established ASVD or a high indicator of CVD risk factors? You will go with GLP-1 receptor agonist or SGLT2 inhibitors. If your patient have already established heart failure, you might go with SGLT2 inhibitor, has the best evidence for such condition. If your patients with type 2 diabetes already have established CKD, you would go with SGLT2 inhibitors. For the weight management, the highest effective glucose lowering agent we have, and it promotes weight loss, the GLP-1 receptor agonist or the dual GLP-GIP. And for management of hyperglycemia, you would choose the medications that manage hyperglycemia and to avoid hypoglycemia. The new things adopted for ADA guidelines to consider what's called MASLD or the non-alcoholic fatty liver disease and not to be under-recognized. People with type 2 diabetes, approximately from 50 to 79%, they have NAFLD or what's called MASLD, metabolic associated liver diseases. And they address to use GLP-1 receptor agonist if necessarily combined with what's called bioglitazone, the glitazone, which has evidence in decreasing what's called non-alcoholic fatty liver disease. Going individualizing which agents you are choosing and try to identify the characters for each molecules. Metformins, don't think it's weak agent, it's potent glucose lowering molecule, the metformin. The good things about it, it doesn't increase hypoglycemia, it's neutral, it might induce weight loss actually, and there's signals toward cardioprotective effects. It's neutral in heart failure, neutral for CKD progression. You would stop it if the GFR below 30. The most common side effect about metformin, GI upset. That's why we started gradually and titrated slowly for patients to mitigate the GI upset. The SGLT2 inhibitors, it's intermediate to high in terms of efficacy, no hypoglycemic risk. The weight loss is intermediate. There is cardiovascular benefit with canagliflozin and empagliflozin. It has a class effect with the heart failure, decreasing hospitalization of heart failure, and it has renal protection with stopping the progression of the CKD or the decline of the GFR. The common side effect of the SGLT2 inhibitor, genital urinary tract infection. And you need to ask specifically for your patient if he is or she is on SGLT2 inhibitors. The GLP-1 receptor agonist, we have oral and we have subcutaneous. It's very effective and potent in terms of glucose lowering effects. It has a weight lowering effect. Doesn't increase hypoglycemia if used alone, but if you will use it with insulin or with sulfonylurea, yes, it will increase risk of hypoglycemia if added to sulfonylurea or insulin. So you need to titrate down the insulin or decrease the dose of sulfonylurea or stop it if needed. Cardiovascular benefit, yes, with dulaglutide and liraglutide, effect on heart failure neutral, stopping the progression of CKD. It's clear that it stopped the albuminuria progression. The common side effect for GLP-1 receptor agonist, GI upset. Okay, you have to be cautious in people elderly, in people with proliferative diabetic retinopathy. Rapid A1C reduction might accelerate their condition. The dual GIP-GLP, we are talking about tirzepatide. Still, the cardiovascular benefits under investigation, but it's very effective, potent glucose-lowering agent with no risk of hypoglycemia, very effective in weight-lowering effect. The DPP-4 inhibitor, I think it's weak to intermediate. Weight effect is not neutral on MACE and heart failure, neutral on CKD progressions, neutral. I don't think we encounter a common side effect with these medications. The pioglitazone, the one recommended if your patient having non-alcoholic fatty liver disease or NAFLD, it might be combined with GLP to mitigate the weight gain, the common side effect with glitazone or pioglitazone. It has a potential benefit for MACE, the pioglitazone, in contrast to the rosiglitazone. And if combined with insulin, be cautious about increased risk of heart failure. No dose adjustment with renal, but the main side effect is weight gain. You might exacerbate heart failure if your patient having heart failure. The sulfonylurea, it's potent glucose-lowering molecule, but it carries a risk of weight gain and hypoglycemia. The first generation increasing cardiovascular mortality, but the second generation, like glimepiride, it has been shown that it doesn't increase cardiovascular mortality, but be cautious with hypoglycemia, especially with elderly or with GFR below 60. Finally, we end up with the insulin. It remains the safest and the most effective glucose-lowering agent we have. The insulin therapy, especially if your patient having long-standing type 2 diabetes with beta cell mass function depleted. So you need to augment your patient, supplement your patient with insulin, either basal, or you might go with basal plus or basal bolus, depends on your patient character. So to end up, to summarize, type 2 diabetes is progressive disease. You have to intervene earlier. If the duration of type 2 diabetes is below 6 years, this is the time primary care physicians are empowered to reinforce the lifestyle intervention, especially the weight reduction. And you might induce remission in those patients if you induce weight loss more than 10 kg and your patient maintain it. At least you will prevent the complication or you will delay it for 1 to 5 years. Don't forget to put your patient at the center of care and to adopt what's called personal central approach for both managing the hyperglycemia and prevent the DM complication. This is the end of my talk. Thank you very much.
Thank you, Dr. Saleh, for keeping us updated on the management of caring for patients with diabetes. Now, we turn our attention to an important topic that is shaping the future of healthcare. The evolving role of family medicine and its subspecialties is crucial as we navigate the complexities of modern healthcare systems. To shed light on this, we have our keynote speaker, who will share valuable insights on how these roles are transforming patient care and improving outcomes. Please welcome Dr. Hind Al-Ghamdi, Consultant Family Medicine, Director of Family Medicine Training Program in King Fahd Military Medical Complex, Tehran.
Assalamu alaikum. Good afternoon, everyone. Thank you all for attending. I'm Hind Al-Ghamdi. As I was introduced, I will talk today about the evolving role of family medicine and subspecialties in healthcare transformation. I would like to thank the amazing team behind Deep Dive for inviting me to speak about this important topic. The title might sound a bit boring, but I promise you it's not. You will learn a thing or two, and hopefully you will appreciate family medicine even more. Okay, so before we begin, let's take a look at the historical or the significant milestones in the history of family medicine in the country. As you know, family medicine as a specialty was recognized in 1972. In 1980, Family and Community Medicine, or FAMCO curriculum, was established in my alma mater, King Faisal University, for undergraduate medical students. 2 years later, Family Medicine Fellowship was established also in King Faisal University in Dammam, followed by King Saud University in Riyadh 10 years later. And finally, Saudi Board in Family Medicine was established in 1995 under Saudi Commission for Health Specialties. Now, traditionally, and this is how I remember family medicine in the beginning of my residency, family medicine focused on these roles within the healthcare system. We are the first contact, the first point of contact for anyone seeking medical care. We provide comprehensive care for all ages, both sexes, acute, chronic problems, all sorts of problems we see in the clinic. And we establish and maintain long-term relationships with patients and their families. And finally, we refer patients to appropriate specialties when needed, while managing most care within the primary care setting. Now, these roles are important, but over the past few years, we have become much more than the first contact. Our role has expanded, and we gained new responsibilities. We are now playing a critical role in diagnosing and treating chronic diseases like diabetes, like Dr. Saleh explained. We are increasingly involved in diagnosing and managing common mental health disorders like anxiety and depression. We offer preventive medicine and health education. We provide urgent care for non-critical and non-life-threatening conditions. And finally, we use telemedicine and digital health like virtual clinics and electronic health systems. So what's the current situation of primary care in the country? Very few articles discuss the capacity of primary healthcare in the country and are usually limited to certain regions or certain sectors. But roughly, we have more than 3,500 certified family physicians, more than 2,000 family medicine residents under training, and more than 2,300 primary healthcare centers. But even with these seemingly large numbers, we still have shortage for family physicians as our population exceeded 34 million. And it's estimated that we need at least 15,000 certified family physicians to fill the gap. Now moving on to our main topic, which is the relationship between the subspecialties and the vision. In 2016, our inspiring leader, His Royal Highness Prince Mohammed bin Salman, announced the 2030 vision. The National Transformation Program is one of the executive programs implemented to achieve that vision. And the first theme of the National Transformation Program is to transform healthcare, to transform it into a new and modern model of care, aiming to create a healthcare that's comprehensive and patient-centered, efficient, sustainable, equitable, and accessible, focusing on disease prevention and health promotion, while utilizing electronic health services and digital solutions. And family physicians play a key role in implementing that vision. So our role is not only expanding in scope, but is also integral to achieving the healthcare vision in the kingdom. Family medicine subspecialties are also an essential part of the vision by enhancing the accessibility, the quality, and the comprehensiveness of primary healthcare in the country. They are integral in addressing the diverse and the evolving needs of the population. We currently have 7 subspecialties in the country and 2 more soon to be coming. We will discuss each one of them briefly and associate each one of them to the healthcare vision in Saudi. So let's start with the most popular one, the Diabetes Fellowship. It's a 2-year program started in 2015. It's currently all over the country in Dammam, Khobar, Riyadh, Qasim, Jeddah, Mecca, and the southern area. Why did we need Diabetes Fellowship? As you know, Saudi Arabia is one of the top 10 countries in type 1 and type 2 diabetes. We currently have approximately 7 million people living with diabetes and more than 3 million with pre-diabetes. Even gestational diabetes has increased 2 to 3-fold since 2010. So we have significant burden by the disease and the complications on both the public and the healthcare sector. So it is necessary to have specialized diabetologists who can offer advanced management and comprehensive management. What role does it play in 2015? By early diagnosis of diabetes, follow-up and prevention of complications, proper management by offering the most evidence-based and appropriate management, ongoing monitoring, follow-up, and appropriate referral for screening. And like we mentioned, integration with the digital health using telemedicine, remote monitoring, especially for patients who live in rural areas and do not have access to proper healthcare. Moving on to the second, also popular women's fellowship, which is the Women's Health Fellowship. It's the first of its kind in the Middle East. It was approved in 2014, and it's a 2-year program, currently only in Riyadh, 3 centers in Riyadh. And it focuses on the acquisition of skills and expertise in the health of a woman throughout her life. Why did we need Women's Health Fellowship? As you know, we have a significant maternal morbidity and mortality, especially with high-risk pregnancies. There's a late diagnosis and management of malignancy, partly due to suboptimal screening, and other important disorders that are more common among women, like osteoporosis and some mental disorders. So the role of Women's Health Fellowship in achieving the vision is offering appropriate antenatal care for high-risk pregnancies, for example, improving maternal health, cancer screening like mammogram for breast cancer, pap smear for cervical cancer, and prevention of some diseases like osteoporosis with appropriate screening, lifestyle modification, and nutritional supplements. Reproductive and sexual health by counseling and educating the patient in different topics like family planning. Geriatric Medicine Fellowship, it's a 2-year fellowship, currently only in Riyadh and Dammam, and for the elderly population above 65 years. Why do we need it so bad here? We are an aging population due to increased life expectancy. It's estimated that the older adult population will comprise 25% of population in Saudi Arabia by 2050. And that means that the adults older than 65 years will exceed the population of children 5 years and younger. So with that aging population, we also are prone to chronic conditions and complex comorbidities, cognitive decline like dementia, and polypharmacy, putting patients at risk for over-medication and drug interactions and other complications of polypharmacy. So family physicians with geriatric fellowship will address the unique healthcare needs for older adults, focusing on management of chronic conditions like diabetes, hypertension, arthritis, and dementia. They will provide home-based care and long-term management to reduce the unnecessary hospital burden. And also they will coordinate with other specialists like neurology, cardiology, to ensure that the elderly patients receive comprehensive and multidisciplinary care. Moving on to palliative care fellowship, which is a 2-year fellowship as well, currently in Dammam, Riyadh, Jeddah, Mecca, and southern area, and it focuses on patients with terminal illnesses or life-shortening illnesses. Like we mentioned, we're an aging population, so we are at risk for chronic and terminal illnesses. Therefore, it's becoming increasingly necessary to provide compassionate care and improve quality of life. Family physicians with palliative care experience are competent in providing pain management, psychosocial support, and end-of-life care for patients with terminal illnesses like heart failure, renal failure, and cancer. By integrating palliative care into the home setting, family physicians can ensure dignified and patient-centered care, improving the quality of life for terminally ill patients. And they will reduce the hospital burden by providing palliative care at home or in outpatient settings, which will ensure that hospital resources are used more efficiently. Primary Mental Health Fellowship. It's a 1-year fellowship currently in Riyadh, Mecca, and Taif. And it focuses on managing, diagnosing the most common mental health issues in the primary care setting. We need this fellowship because we have an increasing prevalence of mental disorders in Saudi Arabia, but still we have very limited access to mental health care. Family physicians specializing in primary health care will be essential in early diagnosis, intervention, and ongoing management of common mental health issues like depression and anxiety. They will play a role in reducing the stigma surrounding mental health disorders, and they will normalize the discussion of mental health disorders at the community level. And they can offer psychosocial support in addition to pharmacological management, improving the overall mental health well-being of patients. Lifestyle Medicine Fellowship, a 1-year fellowship in Riyadh and Jeddah currently, and it focuses on the lifestyle-related chronic diseases. We need it because Saudi Arabia is facing an epidemic of lifestyle-related diseases like obesity, diabetes, and heart disease, mainly due to poor diet, lack of exercise, and high rates of smoking. Family physicians with lifestyle medicine fellowship will play a key role in preventing chronic diseases through behavioral interventions like dietary changes, exercise, and smoking cessation. They will also help manage and reverse lifestyle-related chronic diseases by promoting healthy habits and that improve long-term outcomes. And they can organize community wellness programs to promote active living and healthy eating. Sleep medicine, 2-year fellowship in Riyadh, Mecca, and Jeddah currently. We need it because sleeping disorders, including sleep apnea, insomnia, are becoming increasingly prevalent in Saudi due to modern lifestyles, high stress, and obesity. And sleep disturbance has long-term health consequences on the individuals, like hypertension, diabetes, obesity, depression. Family physicians with sleep medicine fellowship will address sleep-related health disorders like sleep apnea, insomnia, narcolepsy, which contribute to poor health outcomes. And They will help manage the chronic diseases resulting from the sleep disorders. And they can also educate the public about the importance of sleep hygiene and offer strategies to improve the sleep health. Sports Medicine Fellowship. Now, Saudi Arabia is hosting major sports events soon. So this is the fellowship to go now. It's a one-year fellowship approved by the Saudi Commission, but it's not yet started. We need it because Saudi Arabia, as I mentioned, is increasingly focusing on fitness, sport participation, and physical activity as part of the national vision to improve health. And consequently, injuries and performance issues related to these activities are also increasing. So family physicians with the Sports Medicine Fellowship are crucial in preventing injuries, providing rehabilitation, and ensuring safe physical activity. These specialists will also support national fitness initiatives, encouraging the population to stay active and reduce the risk of chronic diseases. And finally, they will help athletes and active individuals optimize performance and prevent overtraining. Now, the last one here is the Urgent Care Fellowship, also approved by the Saudi Commission, but not yet started. And we need it because there's a high demand for emergency and urgent care services, placing strain on emergency departments and hospital systems. Family physicians with expertise in urgent care will help provide rapid treatment for non-urgent, non-critical, and non-life-threatening conditions, reducing the burden on emergency departments and improving overall health access. And also by treating urgent but non-critical cases, they will reduce the waiting times in the emergency departments as well. So in conclusion, each one of these subspecialties aligns with and contributes to the strategic objectives of Saudi Vision 2030 by expanding the role of family physicians in specialized care. Saudi Arabia is paving the way for more inclusive, efficient, and patient-centered healthcare system, leading to best outcomes for the population and the individual. Thank you all for listening.
Thank you so much, Dr. Hind. It's amazing to see how many opportunities we have as family physicians, alhamdulillah. So now it's my pleasure to introduce our next speaker, Dr. Karam Basham, who is a family medicine specialist in King Saud Medical City, who will be discussing an important and timely topic, managing behavioral disturbances in dementia, strategies for improved patient care. Please join me in welcoming him to the stage.
Good afternoon, everyone. First of all, it's an honor to have this opportunity and to present this topic to you. Today, I'm going to talk about managing behavioral disturbances in dementia, strategies for improved patient care. This is my outline. I will go through these objectives in the next few slides. So managing behavioral disturbances in dementia present significant challenges to the patient, caregiver, and healthcare provider. This presentation aims to provide a comprehensive overview of these disturbances, their impact, and the management strategy. We will explore two various of cases, discuss non-pharmacological and pharmacological intervention, and to introduce a structured approach to this complex issue. By understanding and implementing these strategies, healthcare provider can improve patient quality of life and reduce caregiver burden. 90% of dementia patients develop behavioral disturbances during their illness course. These symptoms often leading to increased caregiver stress, hospitalization rates, and premature institutionalization. Early intervention and management of behavioral disturbances can delay institutionalization by up to 2 years. This not only reduces healthcare costs, but also to maintain the patient quality of life and familiar surrounding for a longer period. Behavioral disturbances symptoms can involve the agitation and restlessness, delusion and hallucination, apathy and social withdrawal, depression and mood swings. Common triggers may be involved medical comorbidities such as pain, infection, environmental factors, for an example, noise and familiar settings, unmet needs, polypharmacy and medication side effect. Identifying these triggers early is crucial for effective management. So for management framework, it includes 4 steps. First of all, we need to ensure safety, and it's the priority to establish a safe environment for the patient and others. This may involve removing potential hazards, implementing fall prevention measures, and ensuring proper supervision. Secondly, we have to assess for any underlying causes by ruling out reversible symptoms, for an example, delirium, medical condition, or medication side effect. Thirdly, we have to treat specific psychiatric syndromes such as depression or psychosis. These conditions may require targeting intervention to alleviate symptoms. Finally, we have to develop tailored behavioral strategies by creating individualized behavior modification strategy that take into account the patient's unique needs, preference, and cognitive abilities. This personalized approach can significantly improve outcomes. As our role in primary healthcare, our approach typically begins with non-pharmacological intervention. Such dementia, first line of treatment is non-pharmacological intervention. We can start with the structured routine by doing daily schedule for meals, activities, and rest periods. We have sensory therapy, for an example, music therapy or aromatic therapy. And also we have cognitive therapy such as reminiscence or validation therapy. Such approach can reduce reliance on medication. Environmental adjustment, it's very important, and it can involve by doing by create safe spaces for wandering, improve lighting, reduce noise. Studies found that small group sitting during meals can reduce agitation, while decor adjustment can decrease confusion. So pharmacological intervention, it's only reserved for severe or refractory symptoms. We can start with antipsychotic, such as risperidone or quetiapine, 25 to 50 milligram. We need to monitor side effects of these medications, such as extrapyramidal symptoms or sedation. So moving from agitation to one of the common comorbidities, which is dementia, which is depression. Depression can occur up to 50% of dementia patients. Symptoms may involve low mood, guilt, reduced appetite, and insomnia. It often overlap with cognitive symptoms, and it's very difficult to diagnose depression and dementia. But we have a tool which is geriatric depression scale. We can use it to diagnose depression. Once diagnosed, we can start with engage this patient into activity, socializing, or light therapy. If not improved, we can start with medication. We have SSRI, which is the first line for treatment. We have sertraline or citalopram are commonly used due to their favorable side effect profile and efficacy in older adults. If patient developed any insomnia, we can add on mirtazapine, 50 milligram per day. And we should avoid tricyclic antidepressant due to its anticholinergic effect. Once we prescribe medication, we need to regularly assess this patient and check the medication side effect and efficacy. We have a principle which is start low, go slow principle to minimize the risk factor. And don't forget to periodically follow up with this patient to avoid polypharmacy and to reduce unnecessary prescription. So another comorbidity, which is the pseudopalpar effect, and it's characterized by uncontrolled laughing or crying and related to emotional contest. This usually linked to severe brain or injury or advanced neurodegeneration. Once it's diagnosed, we can educate the patient and the caregiver about the nature of the pseudopalpar effect and to encourage them use of coping strategies such as distraction technique during episode. If not improved, FDA has approved a medication, which is a combined medication, dextromethorphan quinidine, in one pill. It helps to regulate neurotransmitter activity in the brain and reducing frequency of the episode. For prevention strategies for behavioral symptoms, early caregiver education, we need to assess medical comorbidities and to do structured routine. Proactive care can reduce the behavioral symptoms and improve patient outcome. So we have 4 cases. We will discuss the non-pharmacological and pharmacological intervention of each case. First of all, we have Miss A, a 78-year-old patient with a probable Alzheimer's disease, exhibit increased agitation for 3 days in a long-term facility. She is restless, pacing, and resistant to care. Usually, agitation can stem from pain or infection. If we take a deep history of this patient, we need to begin by identifying triggers like new medication or caregiver change. Address these first, and then consider risperidone for severe agitation. We need to start with a low dose, 0.5 milligram, and we can titrate it to 1 milligram. For alternative, we have lorazepam, 0.5 to 1 milligram for short-term use. Our second case, we have Mr. B, an 82-year-old with vascular dementia, shows physical aggressions over several weeks, particularly during dressing. He has struck out at caregiver and family members, causing a concern for safety. Aggression can be response to frustration or delusion. We have to implement distraction technique and gentle remind during personal care. After that, we can consider medication such as quetiapine, 25 to 50 milligram. We can titrate it to 100. For associated delusion, we can give olanzapine 2.5 to 5 milligram. The third case, we have a 68-year-old patient with advanced vascular dementia, exhibit frequent inappropriate laughter episode, particularly during serious conversation or when receiving care. Family members report this behavior has been ongoing for several months and is causing significant distress. So this is the pseudopalpal effect. After ruling out other causes such as mania or frontal lobe disinhibition, pseudopalpal effect is the diagnosis. Once diagnosed, we can educate the caregiver and the patient about the nature of the effect, implement calming strategies and structured interaction to minimize the triggers of pseudopalpal episode. For pharmacological, we can initiate dextromethorphan, quinidine, 10 milligram twice daily. We adjust the dose and monitor for any side effects such as diarrhea, dizziness, or UTI. Our last case, we have Mr. D, a 72-year-old with moderate Alzheimer's disease, appears increasingly moody and difficult. Family report decreased interest in activity and recent issue with diabetes control. Geriatric depression scale assessment indicate moderate depression. So as we said, depression and dementia, it's very difficult to diagnose. A tool like a geriatric depression scale can help us in diagnosis. Once diagnosed, we can start with the 4 steps management. We ensure safety of the patient, assist for any symptoms such as delirium or medical condition, treat specific psychiatric syndrome, and to develop behavioral modification. If not improved, we can start with the medication, SSRI. We have sertraline and citalopram, and we can consider mirtazapine if patient develop any insomnia. To summarize this, behavioral symptoms in dementia require a comprehensive and structured approach. Non-pharmacological intervention is the first line of treatment. Medication only reserved for severe or refractory symptom. Collaborative care can improve outcome for both the patient and caregiver. My home message is to recognize behavioral symptoms early, identify triggers, and tailor intervention to the patient. Balance between non-pharmacological and pharmacological intervention to ensure patient safety. That's what I have. This is my reference. If you have any question, feel free to ask me. Just scan the barcode. Let's open the floor for any question. I am sure that every one of you or each of you has a story from the clinic managing behavioral disturbances in dementia patient. If you have any question, just scan the barcode. Thank you very much.
Thank you, Dr. Up next, I'm pleased to introduce Dr. Mu'adh Al-Ammar, who is a family and preventative medicine consultant in Shagra University, who will be presenting an important topic titled Staying Protected, Latest Updates in Adult Immunization Guidelines. Let's welcome him to the stage.
السلام عليكم ورحمة الله وبركاته. يا هلا والله وسهلا، هلا والله مرحبا. صراحة, it's my honor to be here and to present such a topic for in front of you all, guys. I was happy, to be honest, that let's say Dr. Hind, she talk about different subspecialties in family medicine, and what we attend yesterday and today, it's different topic. We are jumping like from different specialty to specialties, and all these topics is involved in family medicine. That's why our clinic is not a boring clinic. And we are seeing different patients, different age, different diseases, different system. That's what make us make our journey is happy. I know that I'm biased if I talk about preventive medicine, but this topic is a very important topic about the vaccination in prevention and adult immunization. And it's supposed to be early because prevention better than treatment. So what we have here, so it's the latest should present such a topic. I knew that it's not a difficult, but it's not an easy topic. This topic is a little bit hectic because it's for an adult, and there is no clear like guideline or not an easy a guideline for that to follow. It's not like the pediatric schedule. So in 2 months, in 4 months, in 6 months, and some catch up, and it's easy. So for the yes. So what I will talk today about, it's about the review, the latest update in adult immunization schedule. Then we will highlight some important of the vaccine prevention infectious disease, explore a strategy to improve the immunization rate and tackle the vaccine hesitancy, understand the special consideration for high-risk population. So this is the new schedule, which is for 2025, the new updated schedule. It's recently updated from the CDC. We can see here in the left column that it's most of the vaccines that it's needed for the adult population. And we can see in the above in the top row that it's the age specific. This age, it's starting from 19 years old and up to the end of life. So, and there is different color and different coded, which is the yellow one that it's needed for anyone and for anyone at this age without any contraindication. While the purple color is it's recommended for high-risk population, and the light blue color, this is an important thing in preventive medicine as well, which is the shared decision. So we have to discuss with our patient that it's the importance and the risk of this let's say this intervention for his or her condition. While the gray, does not that mean that it's not recommended, but it's mean that we have insufficient data to recommend that vaccine. So what is the updated from 24 to 25? It's these 3 vaccine, which is the COVID vaccine. Now we recommend the new developed vaccine, and we added it's 2 doses, 6 months apart, above age of 65. The other one is for RCV, which is recommended now for the age of more than 75 years old, and the pneumococcal vaccine. And that's, we know that we have like the conjugated, which is the 13, and we have the 23, and now it's replaced by the 20, which is the most having most efficacy. And it's the 2024 recommendation was above age of 65, and now they recommend it above age of 50. So this is the updated adult immunization schedule. So what about the vaccine as a public health success? So we know that the influenza, we are taking the influenza vaccine or recommending the influenza vaccine is annually. And because of what? Because of the CDC that mentioned that it's decreased the severity of the illness by 40 to 60%. And they estimate in 2022 and 2023 that the flu vaccine prevents 6 million flu-related illness, 2.9 million medical visits, and 65,000 hospitalization, and prevent 3,700 deaths. So that has a high economic impact in our health sector in general. While the herpes zoster vaccine, the efficacy is that it has shown over 90% efficacy in preventing shingles and post-herpetic neuralgia for patients more than 50 years. And the long-term data showed substantial reduce in shingle-related complication and hospitalization. So in some countries that who adopt this vaccine showed that decline in shingles-related hospitalization by 50 to 70% in older age. A pneumococcal vaccine as well, so has an impact in phase of pneumococcal disease. So the uses of this vaccine has significantly reduced the pneumococcal infection caused by vaccine serotype and 48% decline in the cases. So that show how important that the vaccine and why the CDC also adopt the lowering the age from 65 to 50 this year. So what about the global perspective? So while widespread adult immunization program have also contributed to reduce the disease transmission within the community, particularly protecting vulnerable populations such as immunocompromised individual, pregnant women, and older adults. So what is the role of the vaccine in controlling outbreak? I think I don't need even to speak about this. All of us saw what happened during COVID. So the COVID-19 pandemic highlight the transformative potential of vaccine in controlling a global outbreak. By what? By reducing the transmission. So the COVID vaccine reduced the transmission of the infection between individual. By what? By decreasing the viral load, by also decreasing the complication of the disease and the severity of illness and the hospitalization, preventing severe outcome, and supporting a global immunity by the herd immunity. So, and economic and social recovery. So it's not about the virus itself, and also it's about what are the complications. Now the depression, and we know that the depression and anxiety, which is come as a complication of COVID. Why? Because it's some of the lockdown and some of the let's say some of the economic loss and because of the lockdown. How vaccine actually act as a first line of defense by preventing disease and spread, and protecting high-risk population, controlling epidemics, and eradication or elimination of the disease, enabling rapid response by making like mRNA vaccines in emergency situation, building a global preparation. And also the vaccine beyond individual protection, which is the herd immunity. I assume that we heard about this phenomena, that if we like controlling or vaccinate some part of the population, that we are helping the rest of the population. Why is that? And how to determine that? We have to determine that by the basic reproduction number, which is, this is a calculate statistical things. It's how individual who is having the disease infecting other. So by calculating this number, we know how many % of the population that we need to vaccinate to prevent the rest of the population. We can see here the blue enemy is having the vaccine. So we are preventing the red people. The red people is not vaccinated. Why they are not vaccinated? Because of many reasons. So protecting people those has cannot be vaccinated for any reason, shielding infant or pregnant woman, maybe the vaccine is contraindication for them, reduce severe of the disease in the elderly population, preventing outbreak in the community, and reducing the economic and social disparities. So what are the strategies for improving adult immunization? So we have a barrier to adult vaccination. I identified the common barrier, lack of awareness or prioritization of vaccine among adults. And this is, I think it's a very important. Now we can see in the social media, some of non-specialized persons and some of the famous people, they are talking in a good or in a bad way about some medical diseases or some medical condition, which is a very important not to let them talk about that, because sometimes they are talking about, let's say, like a personal experience, and this is not an evidence-based thing. So we have to take the lead again and have or talk to our patient by an evidence-based approach, and to give the right knowledge for the right population, and accessibility issues, including cost and availability. And thanks God that we are here in the kingdom, all the vaccines that are available for free of charge, and sometimes they are promoting for people, for families to come to and visit their homes to give the vaccine. Vaccine hesitancy driven by mass misinformation or fear. How to tackling vaccine hesitancy using evidence-based communication strategy and shared success story from public health campaign, like what happened. Like we heard like in last few weeks that the Argentina, they published something about the Tdap vaccine during pregnancy that prevent like almost 80% of neonatal death, and that's on this year. Engaging the healthcare provider. So we want, as I said, that we need to take the lead. Policy and system level intervention, discuss the workplace immunization program and digital reminder, advocate for policies that reduce out-of-pocket cost for vaccine. Who are the special immunization consideration for high-risk population? So who are at high risk? There is different from vaccine to vaccine, but in general, the elderly, more than 65, and individual with a chronic disease that we saw every day in our clinic, diabetes, COPD, and hypertension, and so on. Immunocompromised individual like cancer patient and those who's in immunosuppressant agent, a pregnant woman, and healthcare worker. So I assume that most of us here in this room is high-risk population, and we have to be careful about not receiving vaccine. So there is a specific vaccine as we saw in the previous schedule, and if we go through that, we will have even the recommended vaccine for a special situation. Like in a chronic disease, we recommend the RSV, RZV, and pneumococcal vaccine, and also we recommend hepatitis B and HPV, human papillomavirus, for immunocompromised patient, and hepatitis A, Tdap during the pregnancy for maternal and neonatal protection. What are the challenges in high-risk populations? So we have different challenges, which is the altered immune response. So we have the age-related immune changes. So as individual age, their immune system weakened, leading to diminished response to vaccine. So what will be the impact? The impact will be these patients will require more or high dose of these vaccines. So like the pneumococcal vaccine, the BCV20 are recommended for older adults to protect against invasive pneumococcal disease. And what about the immunocompromised population? People with weakened immune system like HIV or cancer or an immunosuppressive therapy may have reduced vaccine efficacy and sometimes increase the risk of adverse effect of that vaccine. So what will be the solution? Inactivated vaccine, sometimes using some types of or some version of that vaccine will help decreasing the side effect of the vaccine. Modify schedule. So depend on the need of that vaccine. So we will modify the schedule based on their condition. What about the chronic condition for the also elderly conditions such as diabetes, chronic kidney disease, and cardiovascular disease can alter the immune response and increase susceptibility of the infection. So the vaccine is critical for this population, but may require tailored approach. So what is the example of that is like hepatitis B vaccine in patient with a chronic kidney disease may require higher dose or additional dose for adequate protection. And another reason for the complexity is the complex vaccine schedule. So it's not that easy. So multiple vaccine across the lifespan, as we talk in the beginning of this lecture, that it's not like the children schedule or childhood vaccination. Because of the adult, we have a catch-up vaccine like the Tdap and MMR, which is after, let's say, a booster after 10 years. And we have an age-specific vaccine like the shingle vaccine and the pneumococcal, like the pneumococcal vaccine, disease-specific vaccine like hepatitis A for travelers, or condition-specific vaccine, risk-based vaccine like HPV for young adult, or pneumococcal vaccine for high-risk group. So what will be the impact on that complex vaccine schedule? Adult may find it's challenging to navigate which vaccine they need and when. What about the also booster requirement? So some vaccines, such as the Tdap, require booster every 10 years, and COVID vaccine have required multiple boosters to maintain protected against the virus infection. And also there is another issue, which is the co-administration of the vaccine. So adult usually has the fear of multiple vaccination or multiple injection on the same time. Is it safe or not? And this is our rule to know which vaccine that we can give together without any side effect or complication. Practical barrier exacerbating this challenge, so lack of awareness, and this is we have to take the lead here and to aware populations about the need of that vaccine and who need the vaccine and when they need it actually. Access issue. Alhamdulillah, this is, I think it's not an issue here in Saudi Arabia or in Gulf region, alhamdulillah. Ministry of Health, they are providing, and also for the insurance company, they are covering most of the vaccine. So the cost and insurance company, we said that it's covered. Vaccine hesitancy, adult may mistrust new vaccine, like what happened like in COVID vaccine, or perceive them as unnecessarily, especially if they are not ill. And I think we all have this story and have discussion that people come to our clinic and they are discussing the COVID vaccine, that it's causing some complication, or maybe he will have some symptoms and they will mention that I have this after I received the COVID vaccine. And many people, they're coming to me saying that. And usually what I said and what I reply to this myth is, I'm sure that we don't have like a long-term study for the vaccine, and we are not like a defensive people about for the vaccine, but we know that it might have some impact and some side effect, but I'm sure and 100% sure it's more than 90% less than the effect or the complication of COVID itself if I have COVID. So we need time to know what will be the side effect of COVID vaccine. So, and there is a strategy to overcome this barrier. So to tailor the vaccines guideline, simplify vaccine recommendation to be clear and accessible. And with the help of AI now, I think it's an area for improvement and area to develop like an application or whatever that help us as a clinician and help the individual or help the patient to choose the right things to do for the vaccine. So, and enhance the vaccine formulation, like for some people that they will need high dose of the vaccine. Patient and provider education. So we have to educate the healthcare provider on complex vaccine schedule and the strategy for immunizing high-risk group, and raise the public awareness through campaign targeting specific group. Integrate vaccine opportunity, incorporate adult vaccine into routine healthcare visit or workplace health program to improve accessibility. Addressing the hesitancy, as we mentioned, and policy intervention. We have some scenarios, and it will be like an easy scenarios to discuss what the vaccine is needed and based on what age. So like this one is a 45-year-old woman with rheumatoid arthritis is in methotrexate, a disease-modifying anti-rheumatic drugs. So the consideration in this patient is the immunosuppressive therapy reduce her immune response to vaccine. This is one thing. And the live vaccines are contraindication for immunocompromised individuals. So we have these two problems. So what vaccine that we will recommend? So influenza vaccine, we will need it like an annual, and we will avoid live attenuated vaccine. And pneumococcal vaccine, so we will start with PCV 20 since it's covered most of the serotype that we need to be covered. COVID vaccine and shingle vaccine, herpes zoster vaccine, and also the Tdap boosters every 10 years. And also we need the hepatitis B vaccine, HPV vaccine, and RSV vaccine for this people. For that, we call it like immunocompromised patients. So in CDC, they are putting that two categories, the immunocompromised patient and the HIV patient. So they are different groups, and there is a recommendation for each of them. The other scenario is elderly, which is the 68 years old man with COPD and history of smoking. So COPD and history of smoking increase risk of severe respiratory infections such as influenza, pneumonia, and COVID. So we will try to cover this vaccine or cover these diseases. So we will give the influenza vaccine, pneumococcal vaccine, COVID vaccine, and Tdap and shingle vaccine. RSV also, it will be recommended, and the 3 dose of hepatitis B vaccine. Thank you very much. And it was very busy. If there is any question, I would like to hear from anyone. It's fine.
Thank you so much, Dr. Maad. I think we're going to have a break now to pray Asr and come back for 3 o'clock, inshallah. Alaikum. Inshallah, we're going to be starting in about 2 minutes. So if everyone can come in and try take their seats. Welcome back, everyone. We're going to start with a few keynote speakers that I'm looking forward to introducing. First, we have Dr. Malak Al-Shammari giving us an exciting talk from the Saudi Society of Family Medicine titled Pioneering the Future of Healthcare Transformation. Let's give her a warm welcome.
طيب السلام عليكم ورحمة الله وبركاته. يعطيكم العافية جميعا. It's always a pleasure to be involved في deep dive. For those of you who don't know me, أنا دكتورة ملاك عقد الشمري. في الأصل أنا أستاذ مشارك. أنا Associate Professor and Consultant of Family Medicine والhead of Family and Community Medicine Department في الإمام عبد الرحمن بن فيصل University College of Medicine. For a short period, the president or the current president of the Saudi Society of Family and Community Medicine. طبعا في الدورة الحالية. It's been my pleasure إني اليوم أسلم على كثير من الحاضرين. I had the privilege and the honor of teaching as students, as interns and residents. A lot of you today are senior residents. A lot of you are specialists and consultants. And it's just يعني to see you all today. I hope إن I had little teeny influence in choosing the career in family medicine. Okay, so طبعا دائما الكوميتي اوف deep dive يجيبوني اتكلم عن السوسايتي. Today I'm going to talk about the Saudi Society of Family Community Medicine in brief. ونتكلم عن دورنا في society and being the voice of family physicians from all around the kingdom. So just a few words about the Saudi Society. We've been here for almost تقريبا 30 years, but we have transformed like our healthcare system. جعلنا أولويتنا priority تبعنا هي increasing the caliber of family physicians all over the kingdom and playing even if a minor role in the growth, personal and professional في الفاميلي physicians. قبل ما أبدأ وأتكلم عن السعودي Society of Family Community Medicine، إحنا لنا تقريباً 14 to 17 offices around the kingdom. There are liaison offices في جميع مناطق المملكة، مكاتب الرياض، القصيم، تبوك، حايل، الجنوب، طايف، مكة. A lot of our office heads موجودين معنا اليوم. I'm extending warm welcome لهم إن they joined us في الشرقية. الهيدكوارترز تبعنا هو هنا في المنطقة الشرقية. And I'd like to always start my speech by asking the question, why is a Saudi Society of Family and Community Medicine necessary? And what are the challenges that we're facing as family physicians في السعودية? We're chasing critical challenges now for the healthcare sector. There's an increased demand for healthcare services, given our growing population. The cost of healthcare services is high. There is a difficulty in accessing healthcare, and there are concerns regarding the quality and the safety of care. Primary healthcare is undergoing rapid reform in line with the 2030 vision. There were three main important pillars that were adopted. منها facilitating accessibility to healthcare services, improving the quality and the efficiency of healthcare services, and promoting preventive services. So we have started في stakeholders في السعودية to actually shift their focus من investing in secondary and tertiary care to actually investing in primary healthcare services and preventive services. Okay? And there's a real need to develop primary healthcare services that are directed towards chronic disease management and disease prevention as well. We have increased our expenditure in the healthcare sector per capita to almost 0.5% تقريبا, which is much more than what we used to spend في primary healthcare services or preventive healthcare services في the past decade تقريبا. But when we take our numbers and compare them to our same group في industrialized nations, same group في G20, we're still behind. What about the workforce? في primary healthcare services في السعودية. دكتورة هند تكلمت عن بعض الأرقام of registered family physicians في السعودية, and it's really different. It differs من وين تقرأ المعلومة. ف if you're reading from national registries, if you're reading من registries حقت السعودي Commission of Healthcare Specialities, يفرق النمبر, but it's never above 5,000. من وين ما قريت, it's never above 5,000 registered board-certified Saudi family physicians. And the estimated need for full-time family physicians في السعودية, according to our population now, is almost 15,000 board-certified family physician. So there is a very big gap. We're talking about gaps in primary healthcare centers في السعودية and board-certified family physicians to cover this need. And what about this force, the workforce, this workforce? There are a lot of challenges facing these family physicians في workforce now. أول حاجة, more than 70% of the physicians في primary healthcare centers are non-trained GPs. They haven't followed up with board-certified family boards later on, okay? There is a disproportionate mismatch between the annual undergrad influx to the Saudi Society, to the Saudi Commission for Health Specialities, and the intake and the matching of residents as well. So there's a big gap in the influx and the graduates and the seats في الماتشing في هيئة التخصصات السعودية. And the chances to train these GPs already موظفة or already employed في primary healthcare services are almost minimal to none or non-existent. And this directly risks the implementation of the success of empanelment and primary healthcare development. So it's very simply put, you need better quality of care with less costs. Okay, how would you achieve that? By three main pillars. أول حاجة, better care for the individuals, better care for the population health management, and then better health with lower costs. This is how you achieve it. Okay, very simply put. Let's recall the approved initiatives for primary healthcare reform, which all goes تصب كلها في this goal. End goal. What is it? أول حاجة, empanelment, the foundation for systemic national primary healthcare empanelment, plan and design primary healthcare programs, and ensure that these primary healthcare programs, that the workforce in these primary healthcares prepare skilled physicians to manage these population problems. طيب. Now we said, these are the problems. These are the challenges that we're facing. فما هو دور الجمعية السعودية لطب الأسرة والمجتمع في إننا نرفع كفاءة والcaliber of family physicians around the kingdom? I'm humble today إني I share with you some of these very important achievements. واحدة من الأكثر achievements that I'm very proud of is the Journal of Family and Community Medicine. It's a peer-reviewed journal. Our first issue online was in 1994. We have more than 100 issues now online. Alhamdulillah, our scope is indexed. We're in the first quarter of Q1 في preventive medicine, Q2 في general medicine fields respectively. We have increased our publications to 4 issues per year. And alhamdulillah, we are approved in the promotion list for Faculty of Medicine في السعودية and around the region as well. We're committed to publishing original articles and data that really will influence the practice of primary healthcare physicians في السعودية. We're helping primary healthcare physicians to grow clinically and grow personally. واحدة من the prime examples of that is the initiation of Revive FM podcast. It's a podcast from family physicians, made 100% by Saudi family physicians, to family physicians. It touches the most important, prudent, and relevant topics for family practice. Guest speakers are consultants and family physicians from all over the kingdom. We're growing together. There are efforts from our offices from all around the kingdom. مكاتبنا are very, very active, especially lately. في عندنا مكاتب نشيطة جدا في campaigns towards directed towards the population, increasing awareness of our nation and our population. And also there are directed efforts towards increasing the caliber of family physicians also as well. السيمبوزيوم حقنا اليوم is just a prime example of that. Also, improving healthcare practices في primary healthcare is just a priority. It's one of the most important priorities في الجمعية السعودية لطب الأسرة والمجتمع, and that is why we have partnered with Advent اللي هو برنامج الخليج العربي للتنمية in securing a memorandum of understanding في initiative لتطوير مهارات الممارسين الصحيين في مراكز الرعاية الصحية الأولية. And we have important goals في هذا major project. أهمها تنفيذ برنامج إعداد القادة الصحيين أو health care leaders, الطبيب الممارس أو الباحث الممارس, inquiring the best available evidence-based medicine in your daily practices, and also واحدة من أكثر الأشياء اللي ردت علينا بالنفع من هذه الاتفاقية كانت adoption of المرجع الوطني لطب الأسرة. وهو ما يثلج صدري إني كل سنة الحمد لله أعلن في الوقت القريب من الديب دايف عن النيو updated version of دليل FM. يعني يثلج الصدر إن الواحد يتكلم عن شيء أو إنجاز بهذا الكاليبر that is done بأيدي سعودية 100% from family physicians to family physicians سعوديين from all around the kingdom. And I believe that they announced yesterday about the updates of the new version of Dalil FM. So I'm just يعني thrilled إني كل سنة أقدم دليل FM والupdate حق دليل FM. So with that being said, we need your help. We can't do this alone. We want to be your voice as family physicians. We want to hear from you. البرنامج أو المجلس أعضاء مجلس الإدارة للجمعية السعودية لطب الأسرة والمجتمع انتهت 3 سنوات يعني بسرعة كبيرة. سيعلن عن المجلس القادم إن شاء الله في بداية السنة. I urge all of you أنكم تدخلون على الويب سايت تسجلون عضويتكم to be active members and let's hear your votes. خلونا نسمع ترشيحاتكم, خلونا نسمع الفوتينج for مجلس الإدارة القادم الجديد. that I'm sure إنه whoever كان في مجلس الإدارة I'm sure they will carry on مثلنا وأفضل إن شاء الله. But let's hear your voice, okay? Register, vote, and help us help you. وجزاكم الله خير. شكرا جزيلا.
Thank you so much for that incredible and inspiring talk. It'll be my pleasure to introduce our next keynote speaker, Dr. Shabab Al-Ghamdi, Secretary General of the Council of Cooperative Health Insurance, who will be giving a talk titled Shaping the Future of Primary Care, Innovations and Excellence in the Private Sector. So I'm thrilled to welcome him to the stage.
Assalamu alaikum. It seems we have a busy schedule at the year end. 2 weeks ago or a week ago, we were in the same the same place for population health. So it seems there is a lot of action we have to do before the year end. Thank you very much, Dr. Malak and society for inviting us always to your wonderful forum. I will not be. Can we put the presentation? So I will not be that long. I know, guys, it's the day end. It's been a pleasure to be partnered with you over the last 6 years on Dalil FM. I'd like to congratulate all of you on the achievement over the last 6 years. I heard the numbers today. I'm really thrilled to hear from Dr. Malak. Now we have 5,000 family physician board certified. فألف مبروك. الرقم هذا سعدني جدا. I really thank guys, your society and the subject matter expert, either Dr. Malak or Dr. Hadi or Dr. Abdullah. I think he's one of the pioneer in Khneizan and really helping to groom up the new talent. So it's not really anymore a plan, it's an action. So congratulations again. And also, I'm glad to see the new version of Dalil FM, which will stimulate better practice. I'd like just to share with you a status update on where we are going as a transformation. Today, maybe I will remind you, maybe 2019, we established our strategy around how can we help healthcare transformation as CHI. In 2019, the number of beneficiary was 9 million. Today, we are celebrating 13 million who do have a private health insurance. We are pushing toward family practice. We allow insurance company now to invest in primary care and to build the primary care. And MENA, one of the new companies who has established this. So we plan and we acted on it based on our Vision 2030, and I'm sure improving competition in primary care will help us to build better primary care. We allow investors, hospitals, community clinic, insurance company, everybody can compete, and I'm sure this will help to enrich the market. And we are moving toward 25 million of private health insurance. So that the market is huge and the demand is huge. And I'm glad there is a plan by Saudi Commission to produce more family physician. And also our role as a regulator, how can we help to build the right setup of primary care? So this is our strategy 2019 to 24. أبشركم انتهت. حققنا تقريبا كل مستهدفاتها. The most important thing is really developing the ABB, where we include all preventative health screening. And Dr. Hadi was leading this 5 years ago. دكتور عبد الله كان معنا عليها برضه، فدخلنا كل الفحوصات الوقائية. وكذلك we give a preferential treatment if you go through primary care rather than through hospital. Second, we start the Saudi billing system, so all medical services now are coded. We launched the Nafis platform, and we adopt a lot of clinical protocols with your help. Nafis now is having more than billion transaction. We are moving toward DRG and bundle payment and PREMS and PROMs. So most of our objective for 2019 and 2024 has been achieved with the help of a lot of you guys. So where we are heading as a CHI will be part of the transformation coming to the regulator of Ministry of Health. Ministry of Health will be a very thin layer as a super regulator. على غرار هيئة الاتصالات. There will be a health service authority underneath it, which will be merged between CHI, مجلس الضمان الصحي وبعض وكالات الوزارة من التراخيص والاستثمار وكذلك الالتزام وبعض الجهات وكذلك المتعلقة بالكاستمر اكسبيرينس. So إن شاء الله قبل حلول 2027 حيكون عندنا هيئة جديدة، هيئة منظمة الخدمات الصحية، ويصير للبروفايدر one stop shop from license to enablement to compliance. فنعمل خلال هذه الفترة في CHI على أن نعمل استراتيجية انتقالية خلال فترة ال3 سنوات القادمة، ونركز على هذه الفانكشنز. طبعا هتكون تركيزنا بإذن الله مستمر على how can we continue to support Vision 2030, how could we continue to support the HSTB primary care initiative, and also what is our CHI primary care objective. إحنا نبغى النمو يزيد. We want to stimulate growth in primary care. That's why we open for competition, including buyer. Enhancing healthcare services by adopting your Dalil, by adopting care management model, population healthcare programs. 2 weeks ago, we continue to partner with John Hopkins Aramco Healthcare Company about population health. I think primary care is the vehicle and the mechanics to deliver good population health. Population health and value-based healthcare is two sides of the same coin. So we are adopting all of these principles to enhance healthcare services, building trust in primary care center. And as always, I tell my colleagues, we have to earn the trust. People till now, they still think the specialist is better than the primary care. I think if we render the care through passion, empathy, support, good knowledge, good clinical practice, good outcome, I'm sure we will earn the trust. So today, as you can see, 20% of people who do have really healthcare needs. The rest is almost, they don't visit hospitals. However, how can we focus on prevention, bring them in before they get sick, focus on wellness? That's the objective of how can the regulator, CHI, help to build primary care the right model. We know it's a win-win-win situation for all those guys. The beneficiaries, they will have a better access if we provide them with a good setup of primary care, with a good infrastructure, with a good measurement to enhance performance, with the digitalization, with all resources, with a trained staff, with a multidisciplinary approach. So if we do all of that, I'm sure we will win the trust of beneficiaries and will help him to get all of this. He will have a better access, better care, and also ensure convenient access. Providers, our system in the private sector was built around hospital-based. Everybody, maybe you remember in the 80s and 90s, كان الروحة للبرايمري care, it's common. Now أول ما يقولون الناس you need healthcare needs ولا whatever, وش أفضل مستشفى؟ يعني عندك you can go to the biggest hospital. This is part of the marketing, part of the dynamics, how our market, especially in the private sector, was evolving. So I think the challenge here, how can we do a paradigm shift to our beneficiaries? How can we build really a good brand in primary care that will bring people trust back to, and how can we show the value? And this is not easy, actually. It's very challenging. And this is start with a family physician. If we really build a community-based clinic, clinic that provide coordinated care, integrated care, a good quality, I'm sure we will help to shift the paradigm of our beneficiaries. The payer, we are talking here about insurance company. If we provide them a good quality of care with a cost-effectiveness way in terms of primary care, I'm sure they will start to contract with us as a primary care physician rather than going to hospital. And definitely the end is the employer. اللي يدفع البوليص الحقيقي ليست شركة التأمين، هو صاحب العمل. اليوم في المملكة, our economy is now evolving around private sector. So how can we make the private sector grow without the burden of healthcare or healthcare bill for their employee and their dependents? So by adopting primary care, I'm sure will help them to contain their costs and to provide a better quality. So what we did, we have primary care initiatives, classification primary care. We will do it as a CHI and it will be part of Health Service Authority later on. We are measuring primary care performance. We are enabling empanelment. الدكتورة تكلمت عن empanelment. We are adopting a national empanelment program, سواء في البابليك ولا في البرايفت sector. And we are counting on the private sector on the help of the insurance company. And we are capitalizing on تطبيق صحتي اللي we are capitalizing on صحتي platform, which is connected to Nafis platform. So everybody will be helping himself to enroll through صحتي platform. Modification of payment, that's what we did and will continue to do, where we're gonna maybe eliminate all the co-pay related matters for if you go to primary care. Last but not least, accreditation of provider. Primary care branding need your help, guys. We are الرعاية الأولية اسم دائما doesn't really attract many attention. So, and they may think it's really a secondary care rather than. So how can we rebrand ourselves to start with, and then maybe how can we come up with a name that will reflect what we're gonna try to do? And I'm sure our colleagues in CHI and the Saudi Health Council is working now in a project. How can we rebrand primary care? So we define the scope of service, we define the workforce, and we define the technology and the quality and access. So this is the requirement for you guys to practice in community-based clinic for primary care or a hospital or as part of insurance company. And to be accredited by CHI, you have to fulfill this. And we know it's a journey. It's available on our website. I hear Dr. Waliar was with you today. He's our medical director and he's leading this project. And I'm sure he has a better understanding to this project more than me. But once we establish the standard, we need to measure our performance. So we will capitalize on digitalization to measure our performance because this will enhance our performance. The priority primary care measures are those top 10s for the first wave. But as we go, we can measure more of what we are doing and we can enhance and we can excel, either in terms of utilization, quality, outcome, cost. So, we will provide for each provider through Nafis analytics program, your performance in those metrics. And you can see yourself according to the national benchmark. طبعا النفيس analytics is live now. We rolled it out for almost 11 provider. We have 170 KPI. It's meant now for hospital. It's active. It measures, for example, their clinical outcome like length of stay, like readmission rate, utilization, per number of tests per patient per year. So we rolled it out now with the 11 provider. Almost in the first quarter, we will finish first wave of second wave of Nafis providers who constitute 80% of our patients. So we are telling them, guys, regulate yourself before we come and regulate you. So we'll give you a platform where you can see your performance and you can see your peers from the same size. The same program will be launched for primary care. طبعا الزملاء خلال السنة الماضية they launched a program to establish this is what we have done. We did a pilot. So once we established the standard, established the measure, we did a pilot for several providers and we scaled it up and we are testing it now. And our goal is really to expand it and scale it up over the upcoming year and the year after. And we are optimistic with the investment that's coming to the market now. Last week I have, I think it's in Ecuadorian or Cuban. It's from South America. It's coming to invest in primary care in Saudi Arabia. So I send them to you, Dr. Hadia. So this is the primary care program design. Pilot was launched and this is the scale up. And we are optimistic by end of 27, we'll be able to do all of these activity, including empanelment. So again, thank you, Dr. Hadi and Dr. Malak, and all of you guys for keeping us really excited about what you are doing. And really, I'm happy over the last 6 years, you have established a lot and achieved a lot. And I wish you all the best.
Thank you so much, Dr. Al-Ghamdi. Thank you for honoring us with the privilege of your attendance and your excellent presentation, and for sharing your expertise on such promising, incredible achievements in the nation. As for now, we have a very, very exciting event. We have now come and gathered at a time where we should recognize the amazing contributions of the incredible Dalil FM team. We are gathered here to celebrate the excellence and amazing passion, dedication, and hard work they have all contributed to the first national family medicine reference in the nation. So before I go ahead and start, can I please have a big round of applause to the Dalil FM team? To begin, I would like to call some phenomenal, incredible leaders, Dr. Hadi Al-Unazi and Dr. Asil Al-Saimi. Please welcome to the stage. and دكتورة ملاك الشمري. I would like to also call Dr. Muna Maghasla and Dr. Arij Al-Dosari to the stage. So now we will begin by calling the scientific committee of Dalil FM. First of all, we would like to begin with Dr. Tamim Al-Hamed. Dr. Tamim, please welcome to the stage. Once again, thank you, Dr. Tamim. And now we have Dr. Reem Al-Sheikh. Dr. Tasneem Al-Aqzam. Dr. Abdurrahman Al-Arfaj. Dr. Ibrahim Al-Garni. Dr. Arij Al-Aufi. Dr. Hind Al-Ghamdi. دكتور صبا الملا. دكتور مريم بقيس. دكتور نوف البلوي. And now, we would like to mention and recognize some scientific committee members whom poured nothing but their hearts and excellence, but unfortunately were not able to make it today. So we would like to recognize them. Dr. Bender Al-Shihri, Dr. Wasayef Al-Atabi, Dr. Sabahat Khuram, Dr. Muad Al-Khnazan, Dr. Abdulaziz Al-Mutairi, Dr. Mujahid Utaif, Dr. Abdul-Ilah bin Shiha. It seems like we have a special guest who was able to make it at the end. Dr. Muad Al-Khnazan. Dr. Mujahid Utaif, Dr. Abdullah bin Shiha, Dr. Bayan Ajaji, Dr. Ahmed Andijani, Dr. Adil Yaski, and Dr. Daniel Ghaithi. And now I would like to recognize the incredible organizing committee. First of all, we have a very special organizing committee director, whom unfortunately was also not able to come here, but we would like to give her a big recognition, Dr. Daniel Ghaithi. And now for the organizing committees, Dr. Fajr Ad-Dilejan, Dr. Lian Al-Atabi, Dr. Aziza Bukhari. Dr. Faye Al-Ghamdi. Before we move on with the rest of the organizing committee, we would like to mention special consultant who worked very hard as a part of the scientific committee of Dalil FM, who privileged us with her presence today, Dr. Rawan Al-Dahailan. And last but not least, from the organizing committee, we have Dr. Jumana Jarad. It seems that unfortunately, Dr. Jumana could not make it. And now I am incredibly honored to hand over the mic to the esteemed Dr. Hadi Al-Nizi.
Thank you very much. Can you please stay on the stage, ladies? Go back to the stage, please. I just want to, before we leave the organizing committee, I want to acknowledge and thank one of the active, they would say most active members, Dr. Sarah Al-Ali. Thank you, Sarah, very much. Stay on the stage, please. I want to call a very special group who contributed a lot to the momentum of the growth in the field of family medicine, the most important field that overlooked typically by us as a family physician is the research. So we have consultant, expert professors from around the country who contributed to help us grow the field of family medicine. Prof. Abdullah Al-Khnezan, if you want to come to the stage. Dr. Manal Fahmi, if you want to come to the stage. And we are missing Dr. Abdullah Al-Judi, who is not here, but he contributed and contributing a lot. And also Dr. Muhammad Sharif. So on behalf of the Saudi Society of Family and Community Medicine, on behalf of the Dalil FM, thank you very much for your great work and contribution. All the effort of the research and publication cannot be done without your presence. أعطني دقيقة بصور معكم ها. So, before I leave this moment, I want to call and invite every motivated family physician, resident, intern, student, join us. As of today, we've celebrated the Dalil FM Scientific Committee for the year 24. We are calling for you as a family physician, nominate yourself to be part of the journey of transformation. Join us, we are establishing the new scientific committee for Dalil FM for year 25. If you can put the slide for the people who want to volunteer, please. If you can put the slide. So we sure will have the slide for people who want to volunteer. Please make sure to nominate yourself. You want to expand the role of the family medicine. And also, I want to call open all those who are interested in the research and publication, submit your names starting, I would say, Jan 1st, 25. We're going to start the new model for the research and publication under the leadership of Dr. Khnezan and our respected faculty in the field of family medicine. Spark 25 going to happen, inshallah, in May 19 in Riyadh, and the reason we don't change the date because it is the date of the National Family Medicine, International Family Medicine, and we are committed as a society every year to celebrate the National Family Medicine, International Family Medicine Day by our research and publication. Make sure you come forward, and please make sure you submit your names if you are interested to be part of the Dalil FM Scientific Committee 25. As you know, there is only one mandate if you want to be a part of the journey. What is it? What's the mandate? Sky is home and لازم تكونوا من الحالمين. يعطيكم العافية والف شكر. نشوفكم بكرة إن شاء الله. في أمان الله.
تسعين عام والشهادة علمنا وحده وتوحيد وسيف تثنى من يوم أبو تركي تنهض ونجم قاموا لشام العلم محد تونى خلف رجاجيل على قدر الأحداث وانصاح صايح قاضى وفداك حنا وجسنا على المنوى وعيت على الغير وما كل عشاق وصل ما تمنى وإن قالها الله نجعل الحلم واقع ونطوع الصعبات بالعزم منا نبني عمار الدار بأفكار وعلوم ونصنع سلاح جيوشنا في وطننا طق طبول النصر في يوم مجده وسلوا سيوف بالشجاعة تغنى من يوم تركتنا يا